So tell me about Taiwan.
The idea behind your trip to Taiwan. Why did you go to Taiwan when you have the busiest practice in the peninsula?
I don't know if I'm the busiest, but
Okay.
but I'm busy.
You're
For sure I'm busy. I got a little exposure to Uniportal. It was cool, but it didn't feel intuitive.
Yeah.
I thought Biportal might be more intuitive, and John Chen showed me his product. It was sweet. Just got excited about it. I think Biportal's potential future in spine surgery. So I think a long time left in my career.
Why did you feel Uniportal was? Because you do Kanbans through spinology really well. And a lot of times that is just your imaging.
I think being an orthopedist, I think Biportal just feels more natural.
Can I ask you two orthopods, why? You have two hands on the thing.
It's the triangulation.
Yeah.
So it's a triangulation as opposed to just linear. So 3D visualization, and I don't think it's just ortho, maybe neuro guys, they do intracranial surgery. So they're trying to get to the brain through the most straightforward path, but they do it through one line mostly. But for us,
so they're more accustomed to the one line.
Yeah.
They're more accustomed with the one line. We're more accustomed with the two line.
I want you guys to say that.
I think at the end of it, though, is the technology needs to be accessible. So if you price yourself out of the market, and you see this in every industry from NASA's rockets, they simply cost too much, and SpaceX rockets cost less, so they're winning. So the technology, from automobiles to whatever, needs to be accessible. So this idea that you could spend as much money as possible is not based in reality of, especially for a surgery that you could just do open and the patient just takes a couple of days longer to heal.
So can I ask you, what was the trip like? Like, how did John Chen structure it for someone like you? Did he?
So I was basically working. I was working with a doctor.
Like, about your knowledge of it, because I've taken you to that Eloquence lab, right? That was your first endoscopic lab that we did in the city, right? And so,
Yes.
And so your experience on
And I shadowed a surgeon in the area.
Oh, you did?
Hassan. That's his name. Sadiq. Yeah.
You did?
I went there. Fremont Surgery Center.
Oh,
I spent
Dr.
a day with him.
I just spoke to him today.
Yeah. It was awesome. Great experience.
And you did that through Arthrex.
It was all of them. I forget who was the sponsor.
Josh
those guys.
Yeah, I think it was Arthrex.
Sounds right.
Okay.
Yeah, it was cool. Yeah, it was great to see it, but even though it was cool to see, I just didn't feel like I could do it. I was like, how am I going to do that? How am I going to implement that?
Right.
And then when I saw Biportal, I was like, it felt much more intuitive to me. And then I wanted to know more. And so John set me up with this experienced surgeon in Taipei, Dr. Kuo, and he does these every day. So
every day.
Dude, he's so busy. I looked at his week. His week is probably my busiest week of the year. I mean, the guy is just insanely busy. And he's not even just doing spine.
Yeah.
He did a total shoulder while I was there.
He did.
He's doing fracture care. He's like, he loves spine. That's his passion, especially endoscopic spine. But he still does a ton of general ortho. I was like, why do you still do this? Because he's really busy too. But incentives are quite different there, I think.
So, did you get hands-on time in a cadaver lab, or did you just view?
No, I was scrubbed into surgeries with him.
You were scrubbed in.
Yeah.
What an experience!
Very cool. Yeah.
Can we replicate that in the U.S.?
Yeah. So
It's tough, dude. A lot more
Medley not that bad.
Medley goal.
Yeah, Medley.
Maybe in a surgery center.
Surgery centers for sure. But I know in Flagstaff, when Pro Disc C was out, we would go and scrub it and do a case. And it was very helpful.
Oh, that's with Dr. Hall.
Yeah, John Hall.
Yeah, see how I know that?
Yeah.
It was, obviously I didn't do the surgeries, but I got a little hands-on. It was really cool.
What do you think you need? What is the most important thing for endoscopic spine? As you're starting this journey, what is the most important thing for you to learn?
I mean, I think it's just comfort in bringing it to real-life patients.
Yeah.
That next step.
Yes.
I mean, it's one thing to get hands-on for 5 minutes of an hour surgery, it's another thing to actually do it. And
there's a bunch of little decisions that you have to get comfortable making.
Right.
That until you do them, you don't. So the best person that explained their process of how because when he learned, he went to Korea, is Dan Park, not Don Park. So
there's a Dan Park too?
There's a lot of parks.
Park.
Yeah.
There's lots of parks.
Yeah, Don Park I don't want to say learned it from Dan Park. Don Park was doing it well before Don Park got going.
Okay.
He's
Don
just
had
not
to learn
as
from someone.
vocal about it. So Don Park was a Rush resident when I was a fellow.
Oh.
And he was at Michigan and Ann Arbor, and he's going back to Rush because they need him. And he's good friends with Kern, and he's the one that taught Kern how to get going on this. And Kern's taking over it.
Yeah.
But what Dan
I see it all over
is
LinkedIn.
he would start a timer, and he would just do 30 minutes. And whatever he got done in 30 minutes, he did, and then he would stop, and then open the patient up.
Oh, interesting.
Okay, and then see what the heck he did, and learn from it. And he built on that. Yeah, because he said over 30 minutes you get a headache, you messing with CSF flu, especially posterior cervical, and so he didn't let him getting through the learning curve affect patient care.
That's hard though.
Yeah.
Only because I'm going to be bringing this camera that has a cost to it.
Well, with the Biportal, it wasn't
it's
that.
Like some of that pressure.
It was what's available. Yeah, it was whatever
all
available.
The hospitals have those,
yeah, they all had it.
It's not extra.
So he used the arthroscopy scope with.
But I guess, yeah. To be honest, you could probably do it. You could probably do it.
I mean, he's at UCI now.
UCI.
Yeah.
No, he probably doesn't open now. I think he's
no. At
pretty
this point,
now.
that's
brilliant. I
he's
like that. It's a really
past
smart way to.
Yeah.
I mean, I think he just means like you could ramp up to it. You don't have to just force yourself to remain endoscopic start to end. You could always say, hey, I'm going to give myself 30 minutes.
But I think what's important.
See where I'm at.
And I would have a bailout option for you, whether it's a metrics tube or to stay you in the minimally invasive. You do so well in a retractor, and everything.
Or you could just open, whatever you're comfortable with.
Yeah, but that's what.
Open's not bad. But look, I'll just give you an example. This guy was doing hemilams or laminectomies, and it takes him 45 minutes.
Yeah.
And so, so it's like the bony work, the work around the nerves is probably very similar, but the dissection is 5 minutes. So, and then closure is nothing. Put it one stitch and that's it. So you're saving on all the dissection time.
I think the infection rate is definitely going to be
probably
better.
Yeah.
But I think the main thing is you're not having to do the big soft tissue stripping.
And that is not something that's easily measurable by metrics. No, the worst example of that is a posterior cervical procedure, an open posterior cervical. If you measure neurologically, patients are good, but they're miserable patients because you just removed huge chunks of moment arm off their muscles, and their muscles, when you get an MRI, are all infiltrated by fat. So the less you can do to the patient, and we're all taught that in terms of do the least amount. Like if 3-4 is a little bad and 4-5's got the spondy, just fix 4-5 and let the 3-4 be, and it'll deteriorate and you'll do it in 10 years from now. But you do the least amount of surgery possible. But this takes it another way. It's like you do the least amount of messing with the patient's anatomy.
So you could do more levels if you want.
Yeah.
If you're that quick and there's that much soft tissue sparing, you can start doing multi-level and feel like you're really.
Yeah. I think it's going to be the way of the future. And then honestly, psychosocially, I mean, kids like video games. The younger generation coming through, if you give them an option of it's like MIS surgery was for us and our generation. MIS was such a big deal, and now it's not. Everybody does MIS, right? Yeah. But 25 years ago,
nobody did it.
There were all these people that said, you're doing a terrible thing.
And look, you mentioned the video game. I mean, I wouldn't make it a Grey's Anatomy like Call of Duty type video game. I mean, it would be just to, like Dr. Avi said, training, right? Yeah. But very realistic, made by surgeons and spine surgeons.
That's what the neurosurgery board's like. So our boards, everybody has a different board. So our boards, there's a written one, which is pretty straightforward, and there is a oral board, which the surgeons look at your cases.
That's right.
And then they comment on them and say, why did you do this? Why did you do this? For the neurosurgeons,
you have to defend.
You have to defend it.
Yeah, you could basically collect cases for like 6 months, and then of all those cases, they pick 10 or 12 that you have to be prepared to talk about, like in detail, and then they'll ask you various questions, indications, complications.
So you're following all the indications, and
everything.
You're doing. The interesting thing is, isn't there plenty of ways to skin a cat in spine, right?
No, they're okay with that. Yeah. And so when I did
as long as you can
defend it,
really difficult on the rating scale.
No, no. It's not they're not rating your surgical skill. They're assessing your personality.
Oh.
Okay. So they want to make sure you're not Dr. Death. So put it mildly. And so
can you defend your
Can you defend your choices?
If you have complications, can you learn from it?
Yeah. Are you humble?
Can you defend your choices?
And it's really
humility.
Yes. Humility is the number one cause of failure. And so
lack of humility.
Yeah,
for sure.
Exactly.
For sure.
And so I had of my 10 cases, 6 of them were posterior cervical procedures. Okay. And so one of the people that saw it was commenting of, like, I saw your cases, like 6 of them were posterior cervical, and they're not supposed to, you're number 283 or something. They're not supposed to know who you are or where you train, so there's no bias. But I told them, I trained at a place which was very posterior cervical heavy, so I felt most comfortable addressing this. I had a guy needed a cervical corpectomy, 3-level ACDF with a corpectomy, and he smoked 2 packs a day. So there was just no way he was going to heal. So I told him, and I documented in the chart. I said, "You need to stop smoking." And he said, "Doc, you'll get my cigarettes and my guns over my dead body." He was myelopathic. We had to go. So I just did him from the back, and he healed fine. So they want to know why you're doing something, that you're not financially motivated, you have the patient's best interests at heart, you know what your own limitations are, you're not doing something off, and they do lag. So if you show up with a 3-level cervical disc arthroplasty, which I do now, it's not going to be good for you.
Okay, this is a good segue. I'm glad we took endo.
So you'll be conservative during your...
You'll
be extremely conservative during your collection period,
This is a good opportunity to segue into cervical spine. Obviously, we have the CEO of Additive here, and you have a surgeon here, Dr. Abi, who has a booming practice here in Burlingame and San Mateo, San Carlos, the Peninsula, Redwood City, right? Like right over there is Oracle. There's Oracle right there. Can't see it from the camera, but it's right there. Larry Ellison could fly in any moment.
Yeah.
So.
And you guys had the Ellison Center at UC Davis. That was
That's right.
Larry Ellison.
What about?
He gave $7 million to.
That's right. He bought Oracle and they chewed the Golden State Warriors to Chase. Already,
No,
he broke his.
No, he wanted to buy it, but Joe Lake bought it.
He broke his elbow and Mike Chapman fixed it.
He was he wanted to buy it.
Larry broke his elbow skiing in Tahoe, and Mike Chapman fixed it.
Yes, Dr. Chapman was awesome man.
You never met Dr. Chapman.
I did.
You did? Yeah.
So when I was at Davis, he was still somewhat involved. He would come to certain events. I feel like he did some journal clubs.
Yeah, and Dave Mooring.
Really nice guy.
Yeah,
Dr. Mooring?
So Mooring
was still working.
No, he was
still working when I was there.
Yeah.
So I got to meet some of those. Old Dan Benson.
Oh yeah, so Dr. Benson is the first DeWalt Fellow. So the first person to do the Rush Fellowship, which is the Rush Fellowship now, but it really started as the Chris DeWalt Fellowship. So the people that have done it include Dan Benson is fellow number 1, and he was in the Navy. And then subsequent to that, Bridwell was a fellow, and Kim Hammerberg.
Bridwell was Atlanta, right?
Yeah. No, I don't know where he is, but he was with Larry Lanke. And Bridwell Lanke were the WashU guys, but it was really all Dr. Lanke. A little tidbit of gossip for you is where Dr. DeWalt had 2 fellows. One was Dr. Kim Hammerberg, who trained me, and one was Dr. Bridwell. And Dr. Hammerberg got an offer from Dr. DeWalt to stay at his partner, and Dr. Bridwell didn't. And it's always been kind of not the best of terms. And so
the competition,
is
so crazy.
And so
Dude,
it is crazy.
And
I mean, you think San Francisco Giants, LA beat LA?
yeah,
You know, he's been hearing a lot of stories. You know, from a friend of mine who just started a practice, and it's like the mafia saying, "You're not going to make it in this town. Why don't you leave?" That's what some of the conversations have been like. I'm not going to say the geography, but
I had experience like that.
Yeah.
what?
So I was at a cadaver course with Dr. Bridwell as a fellow, and he's showing us how to put in thoracic pedicle screws, and he does it. And he's like, "John, this is how you do it, and you preserve the joint, and you do it this way and this way." And I said, "Oh, that's very nice, but Dr. Hammerberg does it this way."
I'll say, when I did my fellowship on the East Coast, my original plan was to come back, and then as I was there, I liked it there, and I thought about staying, and I explored some job opportunities out there, and my mentors, who were suddenly were not so excited for me to stay in the area, and I was just like, I'm a nobody. I'll be coming out to practice. You guys are 20 years ahead of me. Like, I always found that a little interesting. I was like, why would you be threatened by me? I mean, I'm nobody. But there was this attitude like, I guess we don't want someone else.
I mean, that's changed a little bit. I mean, the Barrow guys were very specific. They had to give you permission to kind of stay in Phoenix if you wanted to, and
See, that's
and
interesting,
then even Dr. Baig, Dr. Crandall was upset. He's like, I'm from here. I like it. Yeah, there is always that whole, and I don't know why, because as you said, but I can tell you, one of the other Rush graduates, Chevy, that's not his, he's at NHSS now. He's like, I see a patient that is coming to me for a second opinion and has already seen Dan Rue. And Chevy's like, why are you seeing me for a second opinion? You already saw
the man,
the Godfather.
What's your opinion about getting second opinions, right?
No, it's definitely. But it's very
I encourage
diminishing.
patients to do it.
Third opinions, especially if they all start sounding the same, then you're
Maybe
really
too much.
a little too much,
Maybe
and
too
you're
much to
doctor
handle.
shopping.
Yeah.
It becomes a waste of time.
If you guys could go
Doctor
back
shop
to
quite
when
a
you
bit.
first started, like even when you were at Valley Medical, right? And when you first started on your first job,
Yeah.
which can you tell me? I know his first job, but what was your first
So
job?
my first job, was with a group called Phoenix Orthopedics with Dr. Landsman. So what ends up happening? Your first job, the first year or two, is really your second fellowship, because you think you know what you're doing, but you're not in the operating room alone with no backup. So all of a sudden, you, as a fellow, are getting these cases done, and you think you're doing them. We talked about this, but one, you always know somebody's got your back. It's like U.S. Marines with close air support.
Yes,
it's a little easier to go charging if you know there's air support, there's evacuation, there's an attending there, and they're going to bail you out of whatever mess almost that you get into. But then, as a young attending, the complication's yours. So I'm very transparent about this. My very first case, it took me 5.5 hours to do a 1-level open lami fusion, 2-level lami, 1-level fusion. And I had a dural leak at the last bite of the last piece.
Yeah.
And I went home and I'm thinking, I'm the only spine surgeon in the world that's batting 1,000. 100%, 100% of my cases get dural leaks. And it was so bad that, so what you do is, you read all the literature there is, you call everybody you can, and you try and figure this out. But then, after a period of time, once you've done it, you've had pretty much every complication there is, you realize, fine, I mean, unless the patient dies, they heal, and they move on, and they accommodate, and everything's going to be okay.
Most do fine.
But in the process of you realizing that for yourself is quite painful, and it's very lonely, because you have no, your spouse doesn't understand. Your professor's like, John, just leave it alone. Don't see the patient. See him in 2 weeks. He'll be fine. And the patient still did fine. I think the thing that's very much missed by everybody, except those that practice medicine, is the fact that you're kind of isolated, and even the patient's just the patient doesn't know what's going to happen, so it's just you and that complication, and the only way you become at ease with that is through experience. So, I talked to my daughter about what's important in life. So there is no way that the number one student in anywhere, Harvard, whatever, that's graduated medical school at the best school, perfect scores, did residency and fellowship, is going to come out and out-operate either one of us, which are, we're experienced, we're regular guys, we've done a lot, very well-trained fellowship and residency. Having said that, there is no substitute for experience at all. And so experience beats out IQ and intelligence and publications any day. And then after experience, the other thing that beats it out is hard work. So the thing you don't want is the lazy guy that just doesn't get the CT scan to check for OPLL, or doesn't, like the hemoglobin A1C is 7.8, doesn't call the doctor and say, hey, why is this patient's hemoglobin A1C 7.8? It's like, oh, it's fine. Like, no, it's not fine. You need to bring it down. So one is experience and hard work beats out intelligence, because at the end of the day, once you hit this IQ that everybody needs to go to college and become a spine surgeon, those couple of extra points, how smart Dan Shuba is, it's not going to help you on an ACDF.